Dr. Matossian, thank you so much for meeting with us at the ASCRS 2017 meeting. You had a presentation, a debate with Dr. Ma about intraocular antibiotics for cataract surgery. Your argument was that transzonular and intravitreal antibiotics are the safest and best option. Can you outline your presentation?
I would love to, and thank you for this opportunity. Cataract surgery is a very commonly performed procedure here in the United States and worldwide. And there are 4 main problems with the current delivery of topical medications. And I have it kind of narrowed down to the 4 C's, as I call them: the cornea, compliance, cost, and of course callbacks to our offices. Therefore, for me, I believe delivering the product, a prophylactic product for infection and inflammation at the time of cataract surgery, is key to address these issues. And for me, delivering it into the anterior vitreous through a transzonular delivery system or approach is really the place to go. And why is that? It's because it's not difficult, although there is a little learning curve. You need a special cannula that's angled to help you get through the zonules, and you're placing the product in the anterior vitreous where you're not worried about quick washout, because you want to have the antibiotic and the steroid there to give you the prophylaxis that you're counting on.
Are there any downsides to the transzonular or downsides that you see to the intracameral approach, where maybe one is better than the other?
The transzonular approach is a little bit more challenging than the intracameral. With the intracameral approach, we're already in that anatomy space. It's a comfortable zone for us cataract surgeons, and we already have a 27 or a 30 gauge cannula on our Mayo tray already. No additional pieces of equipment or a new technique has to be mastered. Whereas with a transzonular, you do need a special cannula, and there are multiple on the market. You do need to get over that learning curve, and as I said, it's not steep, but there is one. Because it's a blind maneuver and you're actually pushing very gently the tip of the cannula blindly through the zonules, potentially you could bump into the ciliary body and cause discomfort to the patient or pain. You could potentially bump the retina and cause a little retinal bleed. And you're depositing a product in the vitreous. So potentially you could be anteriorly displacing the IOL temporarily because of that volume change. So what I do when I make sure I remove some of the OVD before I do my transzonular injection, so there's ample room. Also, the product itself can cause some floaters, so you really have to warn your patients ahead of time that the next day or the evening of the surgery day, they're going to notice a lot of floaters. So forewarning the patient avoids a bunch of the callbacks.
What would you say to ophthalmologists in light of those potential risks? What would you say to convince them that this approach is actually better in the long run?
Delivering the product, the prophylactic product, antibiotic or antibiotic steroid at the time of cataract surgery really helps alleviate many things. One, as I mentioned, is it does not impact the tear film and the cornea, which already is compromised in so many of our patients scheduled for cataract surgery. Obviously, topical drops will exacerbate that condition. Number 2, my second C, is compliance. So many of our patients, as we know, are not compliant. Despite the diagrams that we give them and the schedules that we provide with them with the pictures of the bottles, they're just not going to do it. Or they forget, or they're confused, or they are actually physically challenged, like rheumatoid arthritis or tremors, where they can't squeeze a bottle. Or even if they squeeze, maybe they won't even get the drop into the eye. Maybe they're putting it on their eyelashes or on their cheek instead of the actual corneal surface. And then, of course, the cost. The cost of medications has gone up so much, and less insurances are covering it. Therefore, 3 bottles, assuming there's a steroid, an NSAID, and an antibiotic, per eye per patient, that's 6 bottles. And that in itself is hundreds and hundreds of dollars for the patient for the 2 cataract surgeries. And some patients just don't have it. And then the callbacks to us as practitioners is consuming so much of our staff time, because pharmacists are incentivized to switch to generics. And of course, the frequency of generics is not the same as branded products. So this is leading to confusion and potentially to the suboptimal treatment of our patients. So there's a lot of problems sticking with the traditional way we've done it for centuries of putting drops in the eye, whereas delivering the product at the time of the surgery will really help with at least many of the 4 C's that I mentioned: the corneal issue, the cost issue, compliance, and the callbacks.
As a final take-home message to the clinician, what would you say to them in their practice? What can they take away from your argument that transzonular antibiotics are the best?
Call a colleague, watch videos, come visit, see surgeons who've been doing it, and the company will help you learn and master the technique. It is not hard.